So to continue as much of a sports analogy as I can possibly pull off, we're doing tag team. Okay, so Judy and I have worked together for so long that it sort of comes naturally to us to pass the ball back and forth. So that's what we're going to do. Okay, so now I'm going to be able to move this. Yes? Wrong. Wrong. Okay, maybe it's that way. Yes, it's that way. So what we're going to talk about are the challenges. A lot of people want to give consumers information about price and about cost and about resource use. Well, take a deep breath, okay? Because this is not easy. In fact, this is potentially dangerous. So Judy and I got to do a little study with a lot of help from our friends, including our friend Barbara Rapson, about the challenges in communicating with consumers about cost and resource use. So it had two phases. I'm going to talk about the first phase. Judy's going to talk about the really meaty second phase where we have an actual randomized trial, and then I'm going to wrap up with some of the implications. So the overall study was designed to identify how can we provide consumers with comparative information about provider cost and resource use. We were funded by ARC. They should get the credit for this. And it was done in collaboration with a health collaborative in Cincinnati, Ohio, which was for the first phase, and Massachusetts Health Quality Partners. And let me tell you as a resource how fabulous it is today as opposed to maybe 10 or 20 years ago to have these kinds of partners out in the field interested in learning, interested in participating in research and using research. And I just want to put that out there because it is a change in what our environment is as researchers. So in the initial exploration, we did focus groups. And in the second phase, we did a web-based randomized trial of alternative formats for sharing cost information. So the three focus groups were conducted in Cincinnati, Ohio, with the folks from the collaborative there. All of them, we should note, from a sampling perspective, were people who were getting their insurance through employers. This particular collaborative is particularly influenced by the provider, not the provider, but by the purchaser stakeholder. That's one of the things that it has in common. And one of the things about that market is that there are a lot of folks in that market whose employers are offering them high deductible health plans or consumer-driven health plans. And so of the three puny little focus groups that we did, but there have been more focus groups done since, about two of the three groups were with people who had high deductible health plans. Note that one would have an expectation that those folks would be more price sensitive and more cost sensitive. Not really, okay? So then we also had about half the participants with chronic conditions. So here's what we found out in these groups. Consumers tend to think that when it comes to medical care, more is better. These are the mountains that we have to climb. Some consumers, many consumers really, equate higher cost with higher quality care. And as Judy says, since that's true in every other part of our economy, we shouldn't be surprised that they have this view, not to mention the fact that the healthcare delivery system has carefully inculcated these beliefs in consumers lo these many decades, okay? So we shouldn't be surprised. Many consumers would rather not consider costs in their healthcare choices. Health insurance is something else, healthcare. Some of the people in these groups were flat out offended at the idea that they might have to look at cost and take it into consideration. Also for these groups of people, the term value, as we'll explain, just doesn't compute the way that we use it, okay? Not going there. For example, we asked consumers to respond to a list of definitions of high value in healthcare. I sent Claudia a handout for you folks, which I hope you'll get, which is a list of the statements that we came up with, and we asked people to say which ones they really liked and which ones they really hated, okay? And when we said they could pick 3 of each, they wanted to know, could they pick only 3 of the ones they hated? Okay, so that tells you kind of where we're going. All of the definitions that people really liked focused pretty much exclusively on quality. All the definitions they didn't like focused only on cost, okay? Consumers are afraid that getting value means getting less than the best quality, and this is a core challenge. We need to help people believe that they can get high quality care at a reasonable price, and the term value per se doesn't work, and we still need to do some more work to figure out what works. And I am now going to throw the ball to my dear friend Judy Hibbard.
Thank you, Shoshanna, and good morning. So as Shoshanna said, we're really at the beginning of this process of giving consumers information about cost. And it kind of reminds me of when we were at the beginning of giving consumers information about quality. It's like, oh, we just put it out there and they will come. In this case, they may come to it in a way that we didn't intend, that they understand and use it. So there are some key challenges, and there's some real potential pitfalls with putting out cost information without understanding how consumers may interpret that. So what we learned is that consumers' greatest concern in looking at cost information and using it is that they don't want to get cut-rate health care. So low cost is scary. And we have to, when the way that we present information, we have to counteract that. So as Shoshanna said, we did a randomized web-based trial where we tested different ways to present quality information and cost information in a way that would encourage high-value choices, that is, higher quality, lower cost. And our experiment included employees in high deductible plans as well as those in more traditional plans. And so we know that consumers do care about quality, but we also know that they have a hard time understanding and using the information that's out there. And then when you introduce cost into this, you really increase the complexity of what you're doing, as well as this overlay of beliefs that you have to deal with. So we tested an approach where we looked at no quality information, where we sent what we called a low or a weak quality signal, where it was, I'm sorry to say, like most quality information, a little hard to understand and take in. And then we tried with a strong signal, a quality signal. And how did that affect people's choices, and were they more likely to choose high value? So just to give you some background, here is what the no quality signal looked like. There was comparative information. It didn't include any quality information. And we did actually test different ways of presenting that cost information, and I'm just showing you one. This is the weak quality signal. The information is there. It's a little hard to determine how these things may relate to quality. The information is not presented in a way that's easy to take in. And this was the strong quality signal. And it has what I call the 3-second rule in it, that if you cannot see the best options and the worst options in 3 seconds, your presentation doesn't really work. So here you can pick out, I think, within 3 seconds, at least the top performers. And we also showed top performers that were high cost and low cost. So what we found was that When the quality signal was absent, more people were more likely to use cost as a proxy for quality, and they would choose higher cost. And when we presented the weak quality signal, that was moderated just a little bit. Still, the tendency was to use cost as a proxy for quality and to choose higher cost. When the quality signal was strong, we still saw a little bit of it, but mostly it was gone, that tendency to use cost as a proxy and choose high cost. People were more likely to choose the high value when they could quickly and easily discern that they weren't compromising on quality when they chose the lower cost option. We also observed that confidence in choices was stronger when we gave people a strong quality signal. We also saw, and this is true, we've seen this in other work, that actually interpreting information for consumers helps them. They are in a unfamiliar territory, and the information is complex often and difficult to use. So if you interpret information for the user, it actually is more likely to get used. And our strong signal, in a sense, did that. I'll just go back to that, by saying, well, this is better and this is not. And that's a way to interpret data. But we also interpreted data for people by calling out the high value options. So we showed them that the quality, where the quality was. We showed them about costs. And then we put just a check mark next to the high value options. We actually called it that, but we showed them both so that they didn't have to trust us that this was both quality, high quality and lower cost. And that did help, and people were more likely to choose high value options when you essentially did some of the cognitive work for them. So our findings actually did not differ for those who were in a high deductible plan versus those in a traditional HMO or PPO, which was interesting because these are people who are more exposed to the cost of care, but they still had that core belief that the quality, that cost is a proxy for quality. And so they were, even if they were paying out of pocket, they were more likely to make that high cost choice when they weren't sure about the quality. We also found that the findings didn't differ by demographics, and they did not differ based on health status. We did not include people who didn't have insurance, as this was all employees. So, what are our key takeaways here? Where possible, help people out by interpreting data for them. The task that people face in using comparative quality information is for them to map a good-bad scale onto that information. That's part of the task. If you do that for them, they're more likely to use the information. So instead of saying 80% did this and 30% did that, say this is good or this is excellent. That helps people. And then the other really big takeaway is that I think we always need to pair cost information with quality information, or show this information within quality strata to upfront address consumers' worries that if you, it's okay to choose a lower cost option, then if you are assured of the quality. I forgot to mention, one of the things that we did learn, we went out with this experiment using dollar signs, as you can see in some of the, yeah. So we used, you know, $1 sign less cost, $3 signs more cost. We also tested dollar amounts. We thought this would work, and because it's easier to take in than actual numbers. But it turned out it didn't work very well in the sense that a single dollar sign is actually pretty scary, because we know, like, would you want to stay at the hotel? That's the $1 sign. Would you want to go to that restaurant? Well, maybe not. So it's too ambiguous and fuzzy. So when we actually put the dollar amount in, people were a little more, okay, well, that much difference, it feels okay. So a lot of websites use this dollar approach, and our findings suggested that wasn't really a good idea. Okay. And so in addition to pairing cost information with quality information, we want to make it immediately easy to identify high performers across the various measures using that kind of strong signal. And that really means one screenshot. People should be able to see their options and not have to hold information in their mind, and be able to, the 3-second rule, see the best options. Calling out high value can also help consumers. So, but I think that the big takeaway here is that if we don't do this right, we've sort of raised the stakes on the quality reporting by adding cost. Because if we don't do it right, we're essentially undermining our purpose. That people, if they don't understand the quality information, they're going to use cost as a proxy, and the result will be just the opposite of what was intended. So with that, I'm going to hand it back to Shoshanna.
So what are these negative consequences that we think are going to happen? Not only will the more, you know, if this consumer choice thing works at all, that would mean that the market share would shift to the higher cost providers. What I'm worried about actually even more is that the lower cost providers will start becoming higher cost providers. Because Judy was just talking last night about her very first study, about the same time I was doing my very first study in the mid-'80s, was about physician fee information. And it was the physicians rather than the patients that were more interested in seeing other physicians' fee information. And so, you know, one of the things we've learned with quality information is that it's the providers that really pay an enormous amount of attention to this, and that change their behavior in response to it. So I'm really worried about, as Judy is, about continuing down the line we have been going in terms of a rapid movement towards price transparency. And I want to raise some issues that are really kind of broader and underlying. First of all, I really question the quality of the data that we have about cost and resource use in the first place. And, you know, there were lots of screams and yells about the quality information that we had, and there were a lot of things put in place to ensure the quality of that information, including the creation of a whole organization called the National Quality Forum. We don't have a parallel kind of situation here, and we don't know very much about the data. And anybody who read the Time magazine article from a couple of weeks ago talking about how hospitals bill and what they know about costs would be terrifying to, for example, use the charge master as a basis, which is totally not reality. And you know, so what we could get really in trouble with is not only that, but using wrong data. The other thing is the consumers are not interested, this is very clear, in overall costs. They're interested in the cost to them. They're interested in their out-of-pocket costs. My 25 years ago research project was how to present out-of-pocket cost proxies to consumers, and they really respond to it. But what we need to recognize is that consumers are not interested in you know, one of the reasons they're not interested in cost at all is because they figured that's why they have health insurance. That really is why they have health insurance, so they don't have to worry about cost. So we've really done a number on ourselves in terms of this situation. And so presenting bad cost data is, I think, worse than presenting no cost data. And presenting cost data alone, even if it's good, is not as good as what we've just said, which is presenting the cost data with the quality data, with the framing. And ultimately, we have to work to change the mental model that consumers hold right now. And something like the Choosing Wisely campaign is in one way a step in that direction. But even just the kind of sensitization of the public to what healthcare costs are all about, the way that Marge Ginsburg does in a lot of her work. These are critical things that are all a part of this situation. I'm exactly 33 seconds over. Thank you.